So on behalf of around 1,400 Head Start children and the diverse families we serve in Ramsey County, I would like to welcome you all to the Schools and Smiles presentation. My name is Prashida. I'm a foreign-trained dentist. That's why my accent is so different. So please feel free to stop me anytime you have difficulty understanding my accent. I have a background in public health, and right now I work as a health services manager for Head Start and Community Action Partnership of Ramsey and Washington counties. For my presentation today, I am not going to read everything word by word because I know we just had our lunch, so I would not put you off to sleep. The way I have structured today's presentation is that I want to make it a little bit interactive. So the way I structured is I'm going to talk about the statement of the problem, basically, like talk about oral health issues in our communities, because most of you know that at Head Start we work with low-income children. We will talk about oral health as silent epidemic, and I would like to share a few things around disparity that I see at my work on a daily basis. We would also talk about solutions to oral health as an epidemic, as well as disparities in terms of Head Start. Because Head Start is a program that really focuses on prevention and early intervention. And at Head Start, we have amazing activities, amazing strategies that can be collectively seen as a sustainable model for oral health care. So we are also on top of making oral health care accessible to our families by rendering oral health services during regular school hours while reducing the barriers to health care, such as transportation and financial hardship. So I'm going to talk about some of those strategies. I'm going to talk about some results because, like when I talk about good strategies at Head Start, I will be presenting some evidence-based data that would really back up whatever I'm going to say. And we are also going to discuss few challenges and recommendation. Most of the things that I have on my slide is based on our experience, lessons learned with Head Start, but we'll be adding more to it. And collectively, we'll try to reach to a conclusion. So starting with the statement of the problem, I work for Head Start, and like a typical Head Start family of 4 earns at least somewhere around $24,000. So basically, we work with children from very low income, families. So it's really, really heartbreaking to see these children in poverty experience disproportionate level of oral health diseases. And the kind of disparity that we see, we observe, and we try to overcome on a daily basis is so complex. So disparity in oral health, I think, is very, very complex. It's multi-dimensional, and sometimes I wonder why we do not look at oral health issue in conjunction with social determinants of health. Why do we just look at oral health in terms of numbers? Why do we look at dental caries? 52% of our kids have dental caries. So I think it's time that we dissect those underlying social determinants of health for oral health if we are really talking about, like filling those disparity. It also looks like time has come for people like you and I, who are in the position to make some differences in our community, to collaborate and come together for innovative approaches to reach these socially disadvantaged children. So if you look at this graph, it's so evident that at least 20% of kids aged 2 to 5 have visible cavities. So, and it's a proven fact that dental caries is highly prevalent among the children in US. 5 times more common, 5 times as prevalent as asthma. So we know that we have really made dramatic reduction in prevalence of caries here in the United States. But why is it that we still see a high prevalence of dental caries among socially disadvantaged kids like the ones that we serve at Head Start? So consequently, when there is a high prevalence of caries in our community, caries sequels such as dental pain, missed school days, or let's say orthodontic treatment, or even treatment under anesthesias, these things are going to be more concentrated among socially disadvantaged population, whereas these kids who have really high treatment needs, they are not getting the much needed treatment. So there was a statistics that clearly stated that if a family earns less than $10,000 a year, So children whose families earn less than 10,000 a year have 12 times more restricted activity days compared to their white counterparts, including days missed from school. So to make situations worse, these kids with high treatment needs are not visiting the dentist. Why? Because the families are competing for limited resources. I come from a country where I have seen kids die of diarrhea or cholera, like those simple preventable waterborne diseases, because we do not have a lot of public health awareness. We do not have oral rehydration solution. So when I worked as a community dentist in these areas, it was not possible for me to imagine that our kids would brush their teeth with fluoridated toothpaste, those, like brushing their teeth twice daily with a soft bristle brush and things like that. So I thought it was only a bad scenario in a developing country where I come from. And when I moved to Minneapolis, like the Twin Cities, I saw there were so many nonprofits actively working for oral health of children. There are so many dental clinics in our, in our communities, and everybody is so proactive about reducing the prevalence of dental caries. However, at Head Start, our parents are still struggling with Maslow's hierarchy of needs. We have families without jobs. We have families struggling for food, like real food. So when they come to Head Start, we have to direct them to food shelves. There are families struggling with domestic violence, custody issues. There's so many things that goes on in their life that for a health manager to expect the parents to take their kids for EPSD schedule or to be on top of their dental health or even to bring back the dental papers, it's still a dream. So coming from that extreme to this place, I think my dream is still is not fulfilled, because I think parents are parents and poverty is poverty wherever you are. So again, talking about oral health as a silent epidemic, when a child does not have an access to dental care, she is going to be deprived of dentist-dependent care, such as sealants or fluoride. So that means the chances of a child having oral diseases later in its life it just becomes more. So dentistry has done really well at devising caries preventative and treatment strategies, but these strategies have missed the most needed segment of the society, that is the disadvantaged children. So the challenge now is to develop innovative strategies to reach these children. Because again, going back to those social determinants of health, it's not enough for us to just have dental clinics in our community. Why are parents not utilizing these resources? Why is that our kids have medical assistance, but they don't have a dental exam? So those kind of things must be really, really dissected, and I think that has to be part of the discussion. Again, talking about disparity now. So we know that there is so much of dental diseases and issues in our communities. But the kind of disparity we see at Head Start, I think it just tells us the story of the most vulnerable of the vulnerable. Because I think these kids, they really form a group of vulnerable individuals because of their inability to communicate, because of their dependence, and also because of their relative poverty. So even though we teach a child to brush their teeth and do all the good oral health practices, when they go back home, the parents are still struggling for food, they're still struggling for a job, they're still struggling for a ride. So it's difficult for parents to, fulfill those needs. So even though a child is demanding or child knows good oral health practices, because of those social determinants of health, we have not been able to improve the health of these kids. So although disparity among children is not a new thing for us, I think it's found in every marker of the health. However, disparity in oral health is kind of disturbing because dental caries is the most common chronic disease of childhood. Think of those dental pain, think of missed school days, think of those, abscesses, or just think of the quality of life that our children have when they have all these kind of diseases. It is not a new statistics, but I think it's time to revisit the data that we have. It just looks like children from Hispanic, African American communities, or even Native American communities, the preschool kids, they are more susceptible to have caries experience than their non-Hispanic or white counterparts, which is still surprising because, again, I've moved from a country where I've really worked with absolutely no resources. I've seen kids die of diarrhea because their parents don't know about hand washing and things like that. Coming to a part where I know that there's medical assistance, there's so much things going on, this is the statistics. And I'm like still surprised. Again, utilization of healthcare services is directly related to the income. And 18 million low-income children, the kind of target audience that we serve at Head Start, they went without dental care, including routine exams in 2014. One of the main reasons was that the family was not able to afford it. Again, kids living away from the urban areas are more likely to utilize the already overburdened emergency rooms for simple dental pain or even like for dental procedures. So that's adding a lot of extra money on the taxpayers. So indirectly, we are still paying the cost of not investing in oral health for young children. 3 in 4 children with Medicaid across 4 states did not receive the dental services. What I'm trying to say here is that just because our kids have MA, medical assistance, for example, kids at Head Start, they all technically have medical assistance. Why? Because we are a federally funded program and there is an income guideline. For a family of 4, the income should be less than $24,000 a year. But trust me, we work with poorest of the poor. So even though they have medical assistance, they are not getting the care, and that's where, again, the social determinants of health is going to come in. 59% of these children with Medicaid did not get a treatment. Children of color, again, 12% more likely to experience caries and 7% more likely to have untreated caries as compared to white children in 2010. So again, the disparity could be because children from low-income families do not have access to the dentist, and the only reason why they would go to the dentist is obvious pain or something that interferes with their day-to-day lives. So I was trying to look at some literature around Head Start in specific because the presentation is more or less about Head Start and the good practices we have. So there was this study done to assess the oral health status of preschool children attending Head Start in Maryland. The study found that 52% of the kids had dental caries. The dental care was absolutely underutilized. Another study conducted in Alaska, it found that to treat around 1,400 kids, including a treatment under anesthesia and transportation, the cost was $600,000.
So was there less kids being seen because there wasn't an awareness of where to go? Because even with their Medicaid plans,
yes, so
caregivers or social workers or whoever should be advising them.
exactly.
Yeah,
so that's where it looks like even though they have coverage, they have social workers, and they have all the oral healthcare system in place, still the data was poor. So it means that there has to be something to do with social determinants of health or a few things that we are not even aware of that's stopping them from utilizing the resources that they already have. And they, exactly. And I think that's where I'm going to talk about the accountability piece from our families and a few things that we are facing at Head Start, and that might be able to answer your question. So again, there was another literature around disparity in dental insurance. It looks like poor and minority, kids from poor and minority communities, they had less preventative dental care, and only 22% of the kids they lacked health insurance. And when we look at whether a kid has a dental insurance or no, we are basically looking at the health or dental insurance of their parents. There was a study done here in Minnesota to see if expanding the dental team with a dental therapist would be a better way to deal with the disparity and the epidemic. So the study was done here in Minnesota in one of the clinics where they hired a dental therapist to add to the dental team. And it turned out that the whole program, the initiative was really cost effective, and it really made dentistry accessible to the target audience. So it looks like that could be a possible thing that we could even think of. I'm sorry, what? Yes. Yeah, but then Minnesota is only the state that allows a dental therapist to provide dental care. So that has really made our life a little better at Head Start, because as you all know, it's a struggle to get a dentist, and like with Medicaid reimbursement and things like that. So we have a dental therapist who runs a dental day for us at Head Start, but the dental therapist has a limited scope. So again, it's more like the policy issue for us right now. So that was just the backdrop. So I'm coming to the solution because I'm proud to be associated with Head Start, and we have amazing programs, activities. For those of you who are new to Head Start began as an initiative to find the war on poverty 51 years ago. It started with basically 2,000 children, and it became the trusted cornerstone in communities all over the country with 300 million Head Start graduates. So right now, Head Start and Early Head Start, but we will be referring both the programs as Head Start. Our comprehensive child development program, so we are not just providing education to kids, we are also taking care of their health, their nutrition, their development. So it's more like a comprehensive integrated program that helps our kids to be ready for school. And over 1,400 children from prenatal through age 5 are enrolled in Community Action Partnerships Head Start every year. And we have full day option, half day option, we have therapeutic classes, we have more of home visiting programs, so we have different kinds of strategies to make our program more inclusive. Right now we have 15 centers all over Ramsey County, and our Head Start families, they represent the rich diversity we have in Ramsey County again. Over 20 languages are spoken in Head Start families, and 30% of our staff are bilingual. So that means we are really able to communicate with the newly arrived families in their native language. So there are various strategies and activities for oral health promotion at Head Start. First is the Head Start Act. It's basically because we are a federally funded program, so the government, the Congress really tells us what kind of community we can work with, what kind of races do we need to have in a classroom, how we should be accommodating kids with special needs. So we make sure that we have a certain area that we can work with. We have a poverty guideline, so we would only accept families earning like below $24,000 if a family has like 4 members. So because the guideline in itself is so structured, it just makes us reach out to the most vulnerable communities. So because of that act, I think we are doing the amazing work that we are doing right now. So that just puts everything together. And I'm going to talk about these strategies, just, like I'll just summarize a few of them. So we have performance standards. Because we get grants, we need to tell the government how we are doing with all the grant money in terms of data and other things. So the government tells us to, within the first 90 days, the calendar days, you need to make sure if a child enrolled in Head Start has a dental home. So I make sure, to run around the families to know their medical home, to see if the child is up to date on the oral screening and things like that. And I also make sure to reach out to dental providers so that they provide me with a dental exam paper, so that I can tell the government that, yes, our children have continuous access to oral health care. So our performance standards are very strict, so that just puts us at the top. Because Head Start is basically educational program too for kids. Our teachers have effective teaching practices. Not only we play games with the kids, but we make sure that we are helping them improve their critical thinking, so we engage them in different kinds of conversation. So our teachers make sure that oral health is part of the discussion. As simple as asking them, how do you brush your teeth? Why do you brush your teeth? Or just, acting out as if they're going to a dentist. So it's not only health, running dental days or doing other things around oral health. Even our teachers make sure that oral health is incorporated in a classroom. These are amazing games that most of our teachers, incorporate in the classroom. As simple as having children match oral health related pictures like teeth, toothpaste, and smile to learn about words, reading books with positive oral health messages, or even having children pretend that they are visiting a dental office, or even during circle time just singing some oral health songs. So these are some of the activities that we do in our classroom. We engage parents. That's one of the most important things that we do at Head Start. So we have policy council where we have parents come in and talk about their needs and how we are doing with our treatment and other strategies. So this is the picture from our policy council. So these parents are really, really engaged. And we have health services advisory committee meeting where parents come in. There are like community providers, there are dental providers. So we all come together and discuss about the oral health needs as well, in addition to talking about other healthcare services. We have family fun nights on a monthly basis where we run holistic health series for our families, where we have dental providers come in and talk about some good oral health practices. Helping the child right. So we teach parents to basically help child brush their teeth, because some of the kids from early Head Start, they still need supervision. So we do a lot of parents engagement activities, and we make sure that they are fun, because we think that parents are the most important influence in a child's life. Case management. I think we do a lot of case management because it's not just enough for us to run a dental day and render that treatment. We help parents, we help them get empowered. Earlier, when I started as a health manager, I was very passionate, and then I felt like doing everything for the family, making appointments, running around for them, doing everything. But then later, I realized that it's more important for us to empower those families, especially with low literacy level, because what are they going to do once a child graduates from Head Start? We don't want them to be too dependent on us, so we moved from spoon feeding them to empowering them, where we help them make appointments, call like insurance companies so that we can connect them to care coordinators. We also help them improve problem solving and self-management skills, because some parents, they are really scared of going to a dentist, or like they can't see a child in pain in a dental clinic. So we make sure that we are helping them overcome those fears. We also help them enroll in Medicaid, and we link parents to different kinds of oral health resources. Even though we have our own dental provider, we encourage them to connect to different oral health providers based on their geographic location. We have nutrition services at Head Start that's really, really oral health friendly. We do not have sodas. We make sure that the food have low sugar content. There's no snacking or things like that. There's no vending machine. So that really promotes oral health. And we send out different kind of newsletters where family would learn about healthy food for oral health. And sometimes we have Cooking Matters class where parents are encouraged to prepare a meal that's under $10. So we are not only talking about fancy food good for oral health, but we are also making sure that we are teaching them those strategies to prepare food which is healthy and still affordable. So at early Head Start, because we have home visitors going out to the families, we train them. It's really easy when we have home visitors doing those home visits, because that really keeps us connected to the families. So all our home visitors are trained on oral health skills. So what they do is they use different kinds of forms to assess the risk for oral health among pregnant moms and early Head Start kiddos. That would be prenatal to age 3. And they come back with these forms, and we look at these forms and refer them to the dentist depending on their needs. So this is a picture from one of the home visits. So home visitors are using these egg crates or the containers because we do not have enough models. So this is how we manage to teach our families about oral health. And this has been very fun for our kiddos. And this is a picture from one of the home visits. So at Head Start, one of the best things we have is dental days. This is not really clinical. We've moved from a vertical approach where we are just treating a cavity to more comprehensive integrated public health approach where we make sure that we are doing all the dental scheduling versus parents signing off for a treatment whenever there is pain. So we make sure that these services are rendered at school during regular school hours, and we also take care of transportation and the other costs so that the financial hardship is low. We also make sure that the dental services are equitable, not just that we are filling our dental days appointments, but we really make sure that there's triage, and then the priority cases are treated, and then there is like recall in every 6 months. This is our amazing dental clinic at school. This is one of our biggest centers, and we just upgraded our dental clinic. It's just fun to see kids looking from the window and then being excited to visit a dentist because they don't see other kids crying. So this has really improved the compliance during dental treatment. A lot of supportive services goes in our dental days. For example, we do the dental scheduling. We work with Portico these days, so we run free insurance navigation clinic where our families are screened over the phone, and later we do all the casework for them, and then they qualify for certain kind of insurance. So we're just making it more accessible for them. So Portico is not a private insurance company, but it's a nonprofit that improves the access to insurance. Families who are undocumented, we really have a huge chunk of that, are really taking advantage of this facility. So we connect them to dental homes, family empowerment, as I mentioned, transportation. We make sure that all the transportation to and from the headquarters is covered. And then when it's dental days during school hour, our buses would transport all the kids, and there's no charge to that. And these days we work with Blue Cross, who told us about the Blue Rights. So all the families on Blue Cross public program now qualify for Blue Rights. So we are trying to take advantage of those things. That's covered through the insurance. Language services, we provide on-site interpreters, and everything is covered. Family fun nights and one-on-one counseling. So last time when I attended Schools That Smiles, the summit event, I'm not sure how many of you were there. We talked about many good practices, but there were issues around documentation and how we are going to keep track of all these things. So that's why I'm going to show you some forms and some database that we use. So this is the health history form that all the Head Start kid would have to fill out, and this has a big chunk of oral health. So we are assessing the risk. And this is the form for our providers. So if a child, during welcome days, that's when a child first comes to Head Start, tells us, or the family tells us that they don't have a dental home, we encourage them to sign up for our dental provider who would provide the treatment during the regular school hour. So we have the consent. So it's not that we are forcing families to sign up for our provider, it's more like counseling and really involving them in decision making. This is the dental exam form that we use. It's really simple, but then we still have all the data that we need, because just doing things is not enough. You have to be able to have that evidence-based data. So everything that we do is documented in ChildPlus. That's the Head Start, professional Head Start management software, and most of the Head Starts across the nation use this. So you can see all health data on a single screen. So if you see here, I'm not sure if it is clear, you would see different dental exams there. And then if a rescreening is needed, it's visible on one screen. So that way you know how you are going to follow up with the child. We would be entering health information. I'm sure it's not very clear, but then you can enter about dental home, you can enter about health insurance, so that at least we can provide those kind of supportive services. We can track and view 90-day requirement, because again, that's a performance standard for us. So once that 90-day requirement is approaching, we're going to see different kinds of color coding in the screen that would remind us to make sure that the child gets the EPST oral health screening. We can really view all the health requirements. Oral health is one of it. It's really easy because you would see, so dental exam, you would see complete status. So that really helps us, keep a track of all our kiddos. So early Head Start health requirement, it's basically the same. You would see that oral health care is due, so that means you will have to work with the family and make sure that the child is up to date with his EPSDT schedule. We run different kinds of comprehensive reports so that we know how we are doing with our numbers. And then all the actions. For example, what if a child doesn't show up during a dental screening, or he or she fails to keep up with the appointment? We call the family, so all the communication, all the efforts that we do to make sure that the child gets the oral health screening or the treatment is documented under Action tab. So we also send out health summary to parents, and the teachers discuss health summary with parents during parents-teachers conference. So it's really educating and empowering the families and letting them know where they're at with their kids' oral health. We also send out letters to our families as a reminder that they have to keep up with their appointment, or they have to go and get their treatment done. We have Health Services Advisory Committee. Basically, it's a group of community health providers or our partners or parents who come together and work on strategies to improve the health of our kids. And most of the times, oral health is always on the agenda. So recently, we had a policy approval for classroom circle brushing. And right now, we use classroom. So right now, we have classroom circle brushing at Head Start because our kids brush when they come to Head Start. So at least when they go home, even if they do not brush their teeth or there are like other things going on, we make sure that they are on top of their oral hygiene. So classroom circle brushing, this is just the detail of how it's done in the classroom. It's basically dry toothbrushing where a sink is not required. So that, and it also helps in promoting teamwork amongst the students because it's more like a group activity. So they see each other doing it and it's more like fun activity for them. So recently we had oral health training for our staff. So we are also training our staff on different kinds of oral health practices before we expect them to do that with the kids. These are the different IC materials that we use for oral health. We make sure that we are working with Delta Dental or other nonprofit organization that gives out those kind of IC materials for us. We also have our publications. One publication is called Health Highlights. That's basically Head Start Health for Community Action Partnerships monthly newsletter. The other one is Brush Up on Oral Health. That's from the Office of Head Start. So we have those kind of resources that is helpful not only for us, but for everyone who is working in early childhood area. So talking about the results now, I talked about so many good things at Head Start, and you must be wondering, like, what's the proof that it's working really well? So I'm going to give you some evidence-based data. So this is just for the Ramsey County. It looks like 37% of kids between the age 0 to 5 on Medicaid were able to go to a dentist in the year 2010. So the utilization of oral healthcare services in Ramsey County itself is low. And there is a racial disparity in Ramsey County when it comes to getting access to sealants or getting treatment for cavities. So compared to that, PIR is basically performance information report for us. It's generated using ChildPlus. So what I did here is, so you would see Head Start state and national level. So I'm comparing the data that we have at Head Start with that of the state and national level, just to see where we are at and how we are doing in compared to the state and national oral health practices at other Head Start. So at Head Start, right now we have around 1,800 kids, including Head Start and early Head Start. So even though the total enrollment is different at the state and national level, because all the data are converted into percentage, they are comparable. So dental home. It looks like 99.56% of our kids, they have a dental home. So that means they have continuous access to care. A big reason why 99% of our kids have a dental home is that we run dental days at our schools. So that means even if they don't have a dentist, they can sign up with us. But sometimes the issue that I have with dental homes is that sometimes our kids have 2 dental homes. They would already be going to their own dental provider, but because of convenience factor, they would come and sign up for our provider. So when it comes to billing and things like that, it's kind of tricky. But at Head Start, the priority is to make sure that kids are healthy and they have good oral health, so we tend to overlook that fact. Professional dental exam, 92% of our kids, they received professional dental exam last year, and we are doing much better than the state and the national level data. Preventative care would be sealant and or fluoride both. So 92% of our kids, they did receive some kind of preventative care. At Head Start, around 40% of our kids, they do have some kind of treatment needs. And out of those 40 kids, 40% of the kids requiring treatment, we completed, I wouldn't say we completed, but 90% of them received treatment. Either it was completed or it's still ongoing. So at least 90% had the access to the treatment. So infant and toddler, so when we look at early Head Start, 97% of our early Head Start kiddos, they had their preventative dental services, and we are doing much better than the state and the federal data. Pregnant women, 35% of our pregnant moms, they received professional dental exam in the past year. At Head Start, 99% of our kids, they do have health insurance, but again, just having a coverage does not translate into care. 97.12, that means around 97% of these kiddos, they have Medicaid. So we do not have state-only funded insurance program at Head Start. Private insurance, 2% of our kids, they have private insurance. Pregnant moms, around 100%. So 100% of our pregnant moms, they do have health insurance, and all the pregnant moms are on Medicaid. We do not have any private or state-funded other kind of insurance. So it looks like the numbers are good, so the federal government is going to be happy with us, but that doesn't end the story. The concern here, again, is the challenges that we have at Head Start, especially working with those low-income children. We have limited dentists or, like nonprofits accepting Medicare. Medical assistance. So that really makes it difficult for us to reach out to dentists and, have them treat our kids. The second thing is that parents, sometimes they do not keep the appointment. It's again the social determinants of health. Education, accountability piece, too much of spoon feeding sometimes from us. There is something that I'm not aware of, that parents are not keeping their appointment. Sometimes we are overreaching out to them. Sometimes it's not culturally appropriate with some of the ethnic groups that we work with. They don't want to be called more than 2 times. So it's really kind of a struggle for us to deal with diverse, culturally different families, because that's a strength in itself and we really want to respect that. But sometimes it's difficult for us to understand why they are not keeping up with their appointments, even though they have coverage and we provide the transportation and everything. I think there's some kind of lack of understanding of the importance of baby teeth. So people would think, oh, it's just like baby teeth, we wouldn't have to take care of it. So maybe that's just a general perception. I don't know, that's just an assumption. Dental community awareness of needs of Head Start children and families. This is a real struggle, especially when I'm reaching out to clinics to get their dental records. There's so much of layers at the clinical level that a dentist has to sign it, but a dental hygienist would do the paperwork. So it takes forever for the clinics to return the dental exam form for us. So even though a child might have had a dental exam, we wouldn't know. So that's when parents would sign up for our dental provider, and the child ends up having 2 dental providers, and there are billing issues and so forth. So I think it goes back to social determinants of health, taking care of those insurance, taking care of those educational level, maybe racism or their experience with the system. Recommendation, I think it's high time that we acknowledge the socio-ecological model that we have, not just look at cavities in terms of numbers. It's just not numbers, it's real. It's really, really social, ecological model, I think, where we are empowering individuals through skills, helping them get their dental providers, helping them work out through their insurance and things like that. Interpersonal, organizational, community level, where we have good practices at work, where parents are given flexi time to take their kids to a dentist and they have more flexible hours, or even public policy, because that's the key thing that keeps everybody together. I think community collaboration, because Head Start is not an independent entity. We cannot work as a single entity. We need your support. We need community collaboration, because we are reaching out to those low-income families and their needs are so diverse that we cannot fulfill all their needs. So we would have to really work together to make sure that the socially disadvantaged kids, they have a better oral health. Oral health promotion at all the levels. Maybe expanding licensing for alternative caregiver. I know we have dental therapists, but how about integrating community health workers, at least to apply fluoride varnish? That might be cost effective for us. And simply reimbursement procedures for Medicaid. This has been a big challenge for all the dental providers, for all the nonprofits. So I understand where it's coming from, because I'm a dentist too. I do not practice here, but I understand all the administrative work, but then there has to be something. So it would be really vague for me to conclude with these statements, but I think we have the knowledge, we have the skills, We have the tools to eliminate the suffering of dental diseases for most children, yet somehow we have failed to put the pieces together for our most vulnerable children. I don't know why. I know that there is a gap, there is some fragmentation, but I'm not able to identify where the gap is. Children from families with low incomes, typically the kind of audience that we serve at Head Start, minority children, and those with special health needs have been left behind. The best intentions, the most innovative technologies will not improve the health of America's children until there is a system that actually provides consistent oral health care. That's why at Head Start, we need to make sure that our kids have continuous oral health care, not just one-time dental treatment. We also assume that the problem in oral health practices reaching the community is one of dissemination. However, I think, this is just a personal belief, I think the concept of disparity, equity, and things like that are multidimensional, and it must be viewed in conjunction with social determinants of health. We really need to help family first get food, transportation, those basic needs, physiological needs in the Maslow's hierarchy of needs, before we even think of empowering them in oral health. Because as a parent, if I'm making, let's say, $10,000 a year, and I'm struggling with so many things in my life, I'm not sure if oral health is going to be my topmost priority when I'm still struggling to bring that food for my kids for dinner. I've seen that, trust me. It's just like a struggle with the passion that we have, with the PIR, with the numbers that you have to give to the government, because everything is grant funded, so at the end it's all numbers, numbers, numbers. But really when it comes down to social determinants of health, our families have a different experience. There has been sufficient research to identify the best practices to prevent and treat caries in ideal circumstances. However, we need to have new research studies that takes into consideration the real-life experiences or circumstances of low-income groups, including their experiences interacting with the dental care system. A child is suffering from dental pain. The mom somehow takes the child to a dentist, and she's turned away because the dentist doesn't accept MA. We've had this case. And sometimes I feel it's unethical to just force our parents to sign up for our dental provider, because it's more accessible or more convenient for a mom to go to a certain dentist, offer choice, or maybe there are some factors that work best for them. But how are we going to address these kind of issues? So once they lose that trust in the system, it's really difficult for Head Start or any one of us to rebuild that trust. So we try to do that. We try to make sure that our services are culturally competent. We make sure that we are not talking any scientific terms or things like that with our parents. We really try to validate their concerns, their cultural norms, their cultural practices. We try to take everything into our mind. But still, I feel the kind of population that we work with at Head Start, we still have a long way to go before we think of an ideal oral health situation. So I think that's all.